بسم الله الرحمن الرحيم. معاكم الدكتورة ميرفت أبولمaaty، أستاذ أمراض القلب في طب عين شمس واستشاري كهرباء القلب في مصر وأفريقيا، ورئيس شعبة كهروفسيولوجية القلب جامعة القلب المصرية. هقدم لكم موضوع هام جدا وهو موضوع الساعة عن الأريثميا and COVID. This is for doctors. Severe acute respiratory syndrome coronavirus 2 اللي هي SARS-CoV-2 ده الاختصار بتاعها causes coronavirus disease 2019 COVID-19 because it was discovered in 2019 and has reached pandemic levels. Patients with cardiovascular risk factors and established cardiovascular disease represent a vulnerable group. Patients with cardiac injury in the context of COVID-19 have an increased risk of morbidity and mortality. Cardiovascular risk factor disease and diseases correlate with increasing age. Therefore, our senior citizens and our uncles and aunts are at high risk when they get COVID and cardiovascular complications. Severe COVID-19 infection is associated with myocardial damage and consequently cardiac arrhythmias. Monitoring of the cardiac toxicity of the antiviral drugs used in COVID is of utmost importance. This diagram represents how this COVID invades the cell. The SARS-CoV-2 attaches to the cell membrane and is attached to the angiotensin converting enzyme 2 receptor, and then goes inside the cell into the endoplasmic reticulum and then is getting multiplication inside the cell using the RNA. How about the cardiovascular affection of COVID? We can see that the first vessel affected, or the most important vessel affected, is the coronary artery. Coronary artery affection, this will lead to myocardial ischemia and coronary artery occlusion. And we have cases at Ainshams University presenting to the emergency room with acute coronary syndrome with myocardial infarction. And they underwent coronary angiography, and some of them received thrombolytic therapy as the guidelines first told us, and others received intervention and primary PCI. The other affection is the myocardial cell itself, myocarditis. And when the patient gets myocarditis, some get severe left ventricular dysfunction and arrhythmias comes after. Arrhythmias is a consequence of coronary artery disease occlusion or myocarditis, but some arrhythmias are still observed in the COVID era, and we'll see some examples. These are real cases of patients which are presented and published in May 2020 by this group of investigators, and they recorded 4 types of arrhythmias occurring in 4 types of patients. The first one, this is a patient who had developed complete AV block, and we can see from the ECG escape rhythm with right bundle, and this patient received a permanent pacemaker. This is another patient. We can see from the X-ray how much the COVID is affecting the lung, and this patient developed atrial fibrillation with rapid ventricular response. In this fatal condition, the patient got a prolonged QT, PVCs, and went into torsade de poids, and before that he had prolonged QT interval from the medication and the complication, and he was resuscitated. The third one, this is a patient who presented with cardiogenic shock, and he had ventricular tachycardia, as we see here in this ECG, and at the time the doctors went to him, he had this pulses electrical activity. Unfortunately, he died. In our service, we had 3 cases. Fortunately enough, they came after COVID treatment. And the first one is a resident she's 27-year-old. She got the infection from the hospital, and she had severe respiratory affection, but not necessitating ventilation. She noticed that her heart rate, because she's a doctor, she can count her heart rate at home with the oximeter. And she, after recovering from COVID at home, she noticed attacks of tachycardia, most probably sinus tachycardia at 130 beats per minute. And she was prescribed Procurlan, and she is improving. This is her 12-lead ECG after treatment with Procurlan. This is another case. She is a lady, 64-year-old with normal heart, and she has a family history of atrial fibrillation. Her brother had atrial fibrillation, and she was in sinus rhythm till she got COVID. Immediately after the infection, she had atrial fibrillation. This is her sinus rhythm before a COVID infection, and this is her atrial fibrillation. The atrial fibrillation persisted, although we gave her a treatment. She received medical treatment at home. Her daughter is a good one. She gave her all the medication regimen prescribed by the Ministry of Health at home. We did not start antiarrhythmic drug until she finished her courses. The patient came to the clinic today. We started amiodarone after she finished the intake of the COVID medication, the azithromycin and the plaquenil, the hydroxychloroquine. In order to avoid complication, she was kept on anticoagulation. She was actually kept on Mervat, but the INR when she came today was not adjusted. Therefore, we shifted her to apixaban 5 milligram twice daily. We will give her the amiodarone to continue for 2 more weeks, and she will come for transesophageal echo and elective cardioversion after we make sure that there is no COVID, in order to minimize the spread of infection to the healthcare provider when we do TE. This is another example of a patient who came to the clinic also. He's a 52-year-old male patient who works in a university. He caught the infection of COVID, and after 30 days he still have sinus tachycardia, as we can see from his ECG. His heart rate 104. We did him echo. His echo is normal, because we have to make sure that there is no underlying myocarditis or myocardial affection. He was prescribed beta blocker and procurlan in order to control his heart rate, and he will come for follow-up to see the results. How to investigate arrhythmias in the COVID-19 era? Of course, the 12-lead ECG is of the basic investigation. But remember that the machine can be contaminated. The healthcare provider should protect themselves and should protect the machine from any transmission of infection. But this is the simplest, and this is mandatory. However, from the studies we revised it, no specific ECG changes could be seen in COVID patients. I showed you 3 cases who came to the clinic in order to see but nobody described specific ECG changes. If we get ECG manifestation, we have to exclude affection of the coronaries. If we get S-segment elevation in the setting of myocarditis, yes. And also we have to exclude occlusion of the coronaries. The QT interval is very important to be measured in the beginning of the disease on hospital admission, or even if the patient is going to stay home, we can send him, and I did this, one of our technicians to do him, or our nurses, to do him ECG at home and measure the QT. Why? Because we are going to use drugs which can increase the QT and cause arrhythmias. What are the types of arrhythmias expected with COVID? Atrial fibrillation, as we saw. Here is an example of atrial fibrillation. And I'm going to discuss how to deal with such arrhythmias in the COVID era. Remember these facts. We are going to use anticoagulation in presence of AF in these patients, and we are going to use antiarrhythmic drugs. Remember that the QT prolongation can happen in these patients with chloroquine, hydroxychloroquine, azithromycin, and especially if we are going to use class 1A or class 3 antiarrhythmic drugs. There are increase in the level of the serum level of direct oral anticoagulant drugs with azithromycin and lopinavir and ritonavir. So remember this. So you have to adjust the dosage. Also, the azithromycin and lopinavir will increase the level of the antiarrhythmic drugs and will increase prolongation of QT. This is a diagram of how to deal with the case of AFib. If the patient is hemodynamically unstable, then you have to anticoagulate and cardiovert. Any hemodynamically unstable arrhythmia should be treated with direct cardioversion. If the patient is hemodynamically stable, what we do is we do rate control and anticoagulation. This is mandatory. Then afterwards, we have to think of the rhythm control and continuation of anticoagulation. Here is a diagram of the AFib patient. As we see that amiodarone is the red line, red bars. This means that high risk in presence of during the intake of other medication of COVID. But after finishing the dosage, after checking the QT, we can give it, like the case I showed you. Beta blockers, calcium channel blockers, and digoxin are safe. As you can see, the green bar is for beta blocker. Calcium channel blocker are okay, and also digoxin is okay for rate control. Anticoagulation can be taken. We'll discuss this later. General consideration should be taken caution. Be aware of the indication, contraindication, and the drug-drug interaction between the antiarrhythmic drugs, anticoagulation, and the drugs used in COVID patients. QT interval measurements in the beginning and follow up after the intake of drugs if we have to give it. Even if we are not giving antiarrhythmic drugs, you have to measure the QT in the beginning and after giving the medication, because some people have latent long QT. You have to be aware of it. Class 1A and 1C are contraindicated for patients on COVID who are receiving fingolimod. Patients on fingolimod, ECG prior to antiarrhythmic, ECG at 6 hours and after first dose, and periodic ECGs. Beta blockers are recommended as first-line therapy for rate control. Calcium channel blocker is not recommended if the patient develops myocarditis. Digoxin can be used in congestive heart failure with a beta blocker and calcium channel blocker for rate control. Regarding the anticoagulation therapy, azithromycin increases the effect of warfarin, while lopinavir diminishes warfarin effect. So when you give this, you have to adjust the dosage accordingly. Heparin is the drug of choice for hospitalized patient with atrial fibrillation, especially if the patient is treated with lopinavir or ritonavir. Direct oral anticoagulant can be used in AF patient with COVID after discharge without the intake of the lopinavir medication. For rhythm control, amiodarone for rhythm control in critically ill COVID patient and heart failure can be used, but caution should be taken in the use with if it is used with lopinavir and not recommended with fingolimod. Flecainide is for pharmacological cardioversion in absence of structural heart disease. Ibutylide, which is not available in Egypt but can be used for pharmacological cardioversion if the patient is not on fingolimod. Ventricular tachycardia is a fatal arrhythmia, but you have to treat it, and you might have the patient presenting to it in the COVID treatment, during COVID treatment. As we said, for a general rule, if a patient is hemodynamically unstable, then cardioversion. If the patient is hemodynamically stable, then you have to check for 12-lead ECG to see. If this is monomorphic ventricular tachycardia, then you give IV lidocaine, IV beta blocker, IV amiodarone can be given. If there is no QT prolongation. If there is QT prolongation, then go to synchronized cardioversion. For polymorphic ventricular tachycardia, then you give IV beta blocker, IV lidocaine, and if it is recurrent, then you can go to IV amiodarone. For polymorphic ventricular tachycardia or torsade de points, you treat it like what is in the guidelines for torsade with IV magnesium, isoprenaline, and stop the QT prolonging drugs. There are two conditions which you have to be very cautious. Remember Brugada syndrome. Brugada syndrome can get the full S segment elevation of Brugada when he is exposed to fever. And remember, COVID is fever. So some patients who have Brugada can present to you by marked S segment elevation and the full ECG picture of Brugada because of fever. The second condition is the catecholaminergic polymorphic ventricular tachycardia, which is enhanced by exercise and by catecholamine. In these two conditions, what should we do? In this paper, they said for the catecholaminergic polymorphic ventricular tachycardia, never to give adrenaline, never to give isoprenaline, never to give dopamine, but give beta blocker. Increase the beta blocker, and sometimes you might need flecainide as antiarrhythmic with a beta blocker. For those with Brugada who could develop this marked S segment elevation, some of Brugada patients have already ICD, so they are safe. They can go home and take the antipyretic to decrease the fever, and the ICD, implantable cardioverter defibrillator, is going to take care of his arrhythmia. But in case he gets shocks or get VT storm, then he has to come to the hospital and he has to receive the medication in hospital. QT, corrected QT interval, of course, is very important and gets very highlighted during the COVID era. Why? Because remember, patients are hospitalized. Some of them will need anesthetic agents in order to be ventilated. Some will need antibiotic, antiviral, antifungal, antiemetic, antiarrhythmic, antipsychotic. So all this from this table, you can see that all of these medication can prolong the QT during treatment. And we have to measure the QT interval for those patients before starting any medication. The medications which increase it, we have the zithromycin, lopinavir, ritonavir, also the hydroxychloroquine and the chloroquine. And if the patient has the susceptibility beginning QT interval long, he might go into torsade de pointes, and that was published and was the cause of sudden cardiac death or emergency torsade in the CCU during the treatment of COVID. Therefore, the measurements of the QT has to be corrected. You have to measure it. And also, we have to look for patients who have congenital long QT and those susceptible to prolongation of the QT. And also, we have to check for the electrolytes and make potassium more than 4.5 milliequivalent per liter in order to minimize the hypokalemia and the probability of increasing the QT. Correction of hypocalcemia, hypomagnesemia, hypokalemia in order to avoid the prolongation of the QT. Remember that COVID can present with GIT symptoms with severe diarrhea and severe GIT symptoms where fluids are lost, electrolytes are lost. So correction of these electrolytes is of very good attention, should be given very good attention by doctors. Performing 12-lead ECG, as we said, is very important. If you cannot do it, you can do rhythm strip from the monitor in order to measure and make the correction according to the heart rate. Patients with QTC corrected more than 500, then these are high-risk patients for torsade de pointes and sudden death. And the risk-benefit of the medication for COVID should be weighed against the torsade. Performing an ECG once on treatment, and if the patient gets prolongation of the QTC more than 500 or increase in the QT corrected more than 60 milliseconds, then we have to switch to another medications which does not prolong the QT or decrease the dose and continue the treatment plan. Close supervision or surveillance of the QT, including telemetry and electrolyte measurements, are mandatory during this era. This is how to manage. This is the flow chart. In conclusion of what I said, measurement of the QT less than 500 is okay. Less than 60 millisecond increase in the QT is okay. More than this, you have to stop the drug or minimize the dose. Interaction between anticoagulant and the COVID therapy is very important, especially we are in the era of the direct oral anticoagulants with the dabigatran, apixaban, indoxaban, rivaroxaban, and compared to warfarin and heparin. As I said, heparin is safe, warfarin is safe, but the drug-drug interaction with the warfarin should be cautiously taken. What are the drugs of the direct oral anticoagulants which are safe to be used with the COVID era? We have two, apixaban and rivaroxaban. And remember that the creatinine clearance should be measured and the dosage should be adjusted. Now we have the patient, the arrhythmia patient, who have devices implanted and they want to come to the clinic to make follow-up. We advise them to stay home and not to come except if they have any emergency like VT storm, syncope, battery near end of life. If we can make the home monitoring, which was available sometime in Egypt with the Biotronic devices, this is okay. It's not available in other devices. It is still not in action, but we can ask the patient to measure his pulse at home with the ambulatory digital devices to make sure that he is doing okay. If we can postpone his follow-up, not sacrificing his life. Okay. How about performing electrophysiological study and RF ablation? This was discussed, and according to the guidelines of the European Society of Cardiology and Heart Rhythm Society, they said that don't intervene in a patient for any procedure like ablation, EPS and ablation, except those with high risk of threatened arrhythmia, like VT storm, like incessant SVT. Any arrhythmia which threatens the patient's life should be dealt with thoroughly in the EP lab, and the healthcare providers should be wearing all the PPE, personal protective equipments. I would like to finish with showing all my doctors and the staff how to wear these personal protective equipments in order to protect yourself, to protect your family, to protect your children, and also to protect other patients from being contaminated by the virus. This is the steps with the gown, with the gloves, with the mask, with the head cap, with the overshoes. You have to take care, you have to follow the instructions, make a picture, put it on the wall, follow the instructions in order to save you. Not only this, but also you have to know how to take off your personal PPE, personal protective equipments, safe, thoroughly, in the place. Don't be hesitant to follow the directions, because we want you to be safe and to go back to your family, and family will be happy to have you safe at home. Thank you very much. Dr. Mervat Abolmaaty.